Much, Anna and Lauren.
Thank you so much, Nicole, and thank you, Kara. I'll go ahead and get started. We really appreciate being here. And we see lots of familiar, not necessarily familiar faces, but familiar names. And it's good to see all of you, including current and former partners and staff. And we'll be presenting work that really is a collaboration with a lot of people. And it's nice to see some of those folks here. So we'll be talking about community therapist reports of evidence-based practice strategies, delivery, and how certain strategies predict child outcomes, with a focus on the implications for supporting quality care. Next slide, Anna. So just to give you some background, the context of, or the laboratory of our work that we're presenting today is publicly funded children's mental health services, primarily outpatient and school-based, but children's mental health services. And we know in the context of children's mental health services and other service systems that it's increasingly common that multiple evidence-based practices are delivered for the purposes of meeting the needs, the varied needs of children and their families in the context of services. We also know that evidence-based practices, or EBPs, for youth mental health, they typically include multiple psychotherapeutic strategies that are organized and structured in various evidence-based practice protocols, but some of them are common across evidence-based practice protocols, and some of them are unique or specific to certain targeted problems or presenting problems. And identifying which therapeutic strategies that a therapist may deliver, identifying which one of these or which set of these predict changes broadly in children's mental health symptoms over time. It's really essential for assessing the quality of care. And so that's really the background and context of this work. Next slide, Anna. So we really think about assessing therapist delivery of evidence-based strategies in a couple of different ways, and with some related areas. So we know that fidelity to a specific evidence-based practice is important, and that's really referring to whether a practice is delivered as it's intended. We've really been working in the space of multiple evidence-based practices being delivered. And so we start to think that there's a role for fidelity to those individual interventions, but then also thinking about how, and to the extent that therapists deliver individual evidence-based strategies kind of across the different EVPs. And then really thinking about, is there a subset of evidence-based practice strategies that may be quality indicators, which we can refer to as essential strategies that are common across evidence-based practices that are associated with reductions in child mental health symptoms. So we're really thinking about pragmatically assessing the quality of children's mental health services. So we've really taken an iterative approach to this work across multiple grants, and so we've been working on a tool which we call the evidence-based, or the EBP Concordant Care Assessment, where we really started with getting feedback from practice experts in many different evidence-based practices that could be delivered in children's mental health services for common targets. And using an iterative approach to developing an observer-coded version of this ECA and then a therapist report version of this ECA tool, going back to practice experts, further refining, getting user feedback about how to word questions and so forth. And that what we're really going to focus on today is our predictive validity study that really serves the foundation for developing a brief quality assessment. So what is the ECA? Um, the ECA is the tool that we are using to measure therapist strategy delivery in children's mental health across evidence-based practices. And so what our ECA tool is it includes 37 items, and I will share what those items are, that they assess the therapist delivery of strategies that are considered essential for child mental health interventions. And so for each session, a therapist rates the extensiveness of their use of all of these strategies from 0 to 6, with 0 being that they didn't use that strategy at all, and 6 being that they used it to a great extent. We are clear with therapists that we don't expect all of these strategies to be used all the time. So the first set of strategies are technique items. Those are active methods or the way that a therapist attempts to intervene with or relate to a client or to deliver specific content. Then we have 25 different items that refer to content, and that is really the topic or the substance or issue that's being addressed in the therapeutic intervention. And so this is just an example of how the ECA can look. Again, just the rating from 0 to 6, and we specify what is a content and a technique. So I'll share with you, just to make this more concrete, of what the ECA entails. So the ECA technique strategies include different types of techniques, including those that are around structuring treatment, such as establishing and reviewing goals, tracking progress. Also includes strategies to engage the child or the family. And then many strategies that can be used to facilitate child and or caregiver skill building, such as modeling or live coaching or providing performance feedback. So those are the technique strategies. And then there are content strategies that we've categorized into parenting strategies. So strategies that a parent would be taught in the context of services. Also cognitive behavioral strategies, relating to strategies that relate to relating to others, and trauma-focused strategies. So those of you who are involved in children's mental health services and intervention, many of these likely look familiar to you. So I'm going to turn it over to Anna to talk about our predictive validity study.
Hi, everyone. So I'm going to walk through a study that we fielded in both San Diego and Los Angeles counties. This is a study that straddled across before COVID and after COVID. We were really in the field in the thick of it. And our purpose here was to have community therapists use the ECA in reporting on the EVP strategies that they delivered in sessions with their clients, and to really gather data to identify the individual ECA strategies that we would find associated with child outcome trajectories across a variety of common target mental health problems. So we were interested in were there strategies across the full population of our sample that, when used with greater frequency or extensiveness, predicted better outcomes? And then also, were there strategies that were associated with outcome trajectories, but for specific problem targets? So you can see this was our general logic model of what we were trying to do to identify these items that had this characteristic of predictive validity. So our study we fielded in 21 child serving community mental health programs. We recruited 76 therapists from those programs, and those therapists helped us reach 248 children and their caregivers to enroll in this study. And across the study, we had therapists report on over 1,300 individual therapy sessions. You can see some characteristics there of our caregivers, a very diverse sample, three-quarters Latinx caregivers. And in these two county contexts, a little less than half of the time, therapists reporting on their delivery of care when they were identifying one specific EBP protocol that they were using. And then in the other, slightly more than half of sessions, they were using a more integrative approach. But inclusion criteria for our sample were community therapists that reported being trained in at least one evidence-based practice for child mental health target. Also in the sessions, we had about half of the sessions had some caregiver attendance. Our therapists also were a diverse sample of community therapists, generally more early career folks. About a third were licensed and two-thirds working toward their licensure in community mental health settings. And you can see they were primarily female and majority Hispanic. And more than half of them reported a CBT orientation. Our child sample, quite diverse, and you can see the range of presenting problems here. The common problems of conduct, anxiety, mood, and trauma reported as their major presenting problem. And again, the sample was predominantly Hispanic Latinx. So we measure child mental health symptoms by caregiver report using the brief problem checklist, which covers both internalizing and externalizing symptoms. And we looked at improvement in either total, internalizing, or externalizing symptoms. And our research procedures involved collecting therapist report of their EBP strategy delivery at the session level. And we had therapists report on up to 8 sessions for each child client. And then we followed caregivers over a 4-month period, getting 8 weekly reports of child mental health symptoms, and then again at 4-month follow-up. Just a little descriptive about what we learned about what therapists reported delivering, um, starting with our technique items. Here are the technique items, and you can see pretty frequent reports of delivering these technique strategies at the session level. So the highest being reporting tracking or reviewing client progress, about 3/4 of the sessions that being done. Psychoeducation, very common, using a session agenda, assigning and reviewing homework, and then among this list, the lower frequency item was live coaching of youth caregiver interventions, which some of you may know is a core part of one of the EBPs that has been disseminated in our counties. And then therapists reported on average moderate extensiveness of strategy use. And we do a little bit of orienting our therapists to using the ECHA and helping them anchor for a variety of our items to what would be considered low or high extensiveness for these strategies. And then as far as the common content covered in sessions, and again, this is across our full sample, regardless of presenting problems, we see a high frequency use of EBP strategies related to parenting, those positive reinforcement strategies of teaching rewards and praise, some affect education work, a CBT strategy, um, and almost half of the sessions, therapists reported using cognitive restructuring. You can see Um, some of our 25 content strategies not appearing on this list in terms of the most frequent things that you might notice aren't here are exposure, for example, which was a lower frequency content strategy. And again, we get a sense of what strategy, the average extensiveness with which therapists reported using those strategies. Those of you who track outcomes in your systems of care probably know that we expect to see mental health symptoms decrease over time in treatment, and we did observe a nice average level of improvement across children in our sample. And then we wanted to know which ECHA strategies were associated with changes in child mental health symptoms overall, again, which had predictive validity. And I'll just sort of editorialize here to say that, Lauren and I weren't sure what to expect in terms of, a single item and extensiveness ratings of given single items of EBP strategies by therapist report across 8 sessions. What could we expect in terms of associations, significant associations with child outcome trajectories? Um, so we were a little we were holding our breath for a long time when we find evidence of predictive validity in this way, because as there are a lot of questions about reliability and so on, and demand effects when we look at therapist report of practice delivery. So anyway, starting with our ECHA technique strategies, we actually found 6 items where the average extensiveness or frequency of use, of reported use of these techniques were significantly related to changes in child symptoms in our overall sample across all child presenting problem types. So that's really exciting. One note here, though, was that the addressing barriers item was an unusual case where greater therapist reported use of motivational enhancement techniques was related to less improvement in symptoms. And we've been examining explanations for this surprising direction, and perhaps we can talk about that more in the Q&A. But given this direction of this effect, we would not then consider this a quality indicator. Okay. Moving then to all these content strategies and which ones predicted outcome trajectories in our full sample across problem types, only the average extensiveness and frequency of cognitive restructuring was related to changes in child symptoms in the overall sample, combining across problem types. And this might make sense that, we don't expect when it comes to content, high average extensive use of all of these items across sessions, right? Because that would be a pretty chaotic session or sessions if therapists attended to many, many types of content. So the average extensiveness being high across sessions. We probably really want therapists to be focusing their content on, strategies related to specific presenting problems. So we then asked which content strategies were associated with symptom trajectories for children when we look at specific presenting problems. So here we're looking at content strategies, and you can see again organizing them by type of content. And we'll just go through for each of our major child targets. Did we find evidence that content extensiveness predicted child outcomes? So for conduct problems, we found again cognitive restructuring, assertiveness training, and one of our parenting strategies, actually distracting and redirecting, were associated with improvements in conduct in outcomes for children presenting for conduct problems. For trauma, we found exposure, cognitive restructuring, relaxation, youth education support, and then specific trauma-focused content, common reactions to trauma, and safety skills, all related to better outcome trajectories for children presenting for trauma. And then for mood, we found actually some behavioral parent training items, as well as cognitive restructuring and actually common reactions to trauma, also related to more improvement for children presenting from mood problems. So overall, we found evidence for these content strategies perhaps functioning as quality indicators in the treatment when we looked at differentiated presenting problems. And so these might be candidate content strategies that we might consider for inclusion in a quality assessment toolkit. So some takeaways from the predictive validity component of the study: therapists are reporting meaningfully on what they were doing in session in ways that did predict child outcomes. Across all presenting problems, we found cognitive restructuring content and techniques around that help therapists structure sessions and treatment and build skills were associated with outcome trajectories. And then for specific presenting problems, an additional 9 content strategies were associated with outcome trajectories. Turn it back over to Lauren.
Thanks, Anna. So so as Anna shared, we weren't sure if any of these 37 ECHA items would be associated, if any of them would be associated with um, trajectories, and so we're pleased that we found that, um, and and ultimately our intended use of any quality indicators is really moving towards action as far as developing a toolkit that might be useful for therapists or supervisors to be able to quickly and pragmatically assess the quality of their delivery of evidence-based practices. And so as part of ultimately developing a toolkit, we really felt it was very important to go back to therapists and get therapist perceptions of how it was to use the ECHA. And we have done that, as I mentioned, throughout the development of the ECHA, is to go back to therapists and get their feedbacks on how do we word things, what would be easier to report on their practice and so forth. So this is kind of consistent with our approach. So we started by asking therapists, we wanted to know, in the predictive validity study, where they just, during their sessions with participants, completed the ECHA for a given session, we wanted to know what it was like for them. And just as a reminder, or procedurally, when we were doing this predictive validity study, we did not provide any scores or information back to therapists. All they did was report. And so, so again, we wanted to know their experience just filling it out in the study, and then for them to think forward as being part of a toolkit to support quality of care. Next slide. So what did we hear from therapists? Well, first of all, they really indicated that it was feasible to use the ECHA. So they thought it was easy to use. There's some quotes on here. It was really intuitive. It made sense. It flowed. It was user friendly. And that it didn't take that long after sessions. We're really mindful that therapists have a lot to do during and after their sessions. And so we were really had an eye on that it didn't take too long for them to do that. And this is the full ECHA with 37 different strategies after their sessions. Next slide. They also indicated some areas where they really felt it was very acceptable, and useful. And we have heard this theme before in that the therapists, again, not receiving any scores, just the process of filling out those items after sessions, that they felt it was a very helpful reminder and about evidence-based strategies, and that it helped them stay accountable. And that it also was helpful for shaping a plan for the sessions, in thinking I should do one of these strategies more often or not. One of the things we've often heard in different parts of our studies is that also completing the echo is helpful for progress notes. I think it gave a language for therapists to characterize what they did in a given session, and they've reflected on it after the session. So, and again, they're saying we really enjoyed it. It helped me with my notes and sometimes with the interventions, and that just rating what they did was very helpful in a number of ways. So that was we got a lot of very positive feedback about just filling out the ECHA on its own. So that was reflecting back to what the therapist had done previously. Then we asked them about how the ECHA could be used in a future toolkit to support the quality of care. Next slide. So what we did is we generated kind of a prototype where we showed therapists, a potential report that showed, program level in the blue bars. It reflects program averages for different strategies, and then the orange line was that therapist use of a given strategy that they reported on. So we just had them think this was just one prototype, and we asked them, what would it be like to have this information shared with your supervisor or the program, and then ask them to kind of imagine what it would be like if we had presented data in this way. Again, we didn't do that. This was kind of hypothetical to get their feedback. Next slide. And so, the therapists really gave us some good information about how it would be beneficial, not just to complete the ECHA, but to receive the feedback on scores and so forth. And they really, we saw a number of comments that having the feedback reports and score reports would enhance or could enhance supervisor feedback and could elicit supervisory feedback. And so somebody, example, I think it would be really helpful in supervision to go over it with your supervisor, talk about, for example, why is exposure so low compared to the average, and to really kind of dig in on what's happening. And that they thought that it would be that could be really useful to get feedback and to generate discussions in supervision. They also thought that having those reports and feedback had the potential to increase or to enhance both individual therapist and program development. So, for example, this therapist saying it's informative for us as therapists and as a program to know what we're doing and what we could improve, and that it could be, from an individual perspective, a way to see areas that I need to improve on or focus on more when delivering therapy to clients. So, additional beneficial use that therapists highlighted was, again, that promoting accountability. So this one, I knew that if I was going to receive feedback on it and I would get these data, I probably would take more time to really think about how much did I praise, or if I'm only using verbal praise, how I can elicit more. So really thinking about the depth of their use of evidence-based strategies. And the utility of related to accountability of reporting on practice. So this is similar to what we heard when therapists were talking about what it was like to fill out the ECHA in the predictability study. They also highlighted, we know in county children's mental health programs that there are many trainee therapists or pre-licensure therapists who are receiving supervision. The ECHA was perceived as developmentally appropriate among trainees and useful. There are some comments reflecting about their status in their training as far as always learning something new, and it would be particularly beneficial at this stage for them to use the ECHA as their in their training, provided a structure. There was also some comments about the feasibility of going to scale with the ECA, meaning that if the ECA were intended to be used with all clients and all sessions, there were some concerns about the feasibility there. Um, so there's a comment here. So I think that initially it could be like one more task. I mean, one thing that there's so many tasks in these settings, so much paperwork that it could be overwhelming to do this for all and stressful to do it for every single client for every single session. And so that would be an important consideration if we were going to move forward and include the ECA or part of the ECA in a toolkit. There also were some other concerns that were raised. Um, therapists were really expressed concerns about using the feedback from the ECA for the purposes of performance evaluation. So they really liked the idea of using the ECA for individual development as a therapist and for a program, but had concerns that it may be used in performance evaluation and that it really that there were some caution in doing so. And there um, and to be cautious about doing that because the context of that session wouldn't necessarily come through in the data and the report if it were just scores. And there's always the bigger picture. And there were explicit comments about how it could be used against them in a performance evaluation, especially if there wasn't context provided. So that was some concerns and caution. There's some additional concerns, again, that were related to limited context for interpretation. So it's possible that the ratings are really client dependent and case dependent and probably session dependent as well, and that there's the potential for that to be missed. And the barriers that therapists face there's the potential for that to be missed as well and misinterpreted. They also reported that there was the potential for response bias if they knew that it was going to be used to criticize them, and that the therapists would likely rate themselves higher. So all important cautions in developing a potential toolkit. So as far as some key takeaways about that, what we've learned from our qualitative data is that that therapists really found the ECA helpful for self-monitoring, supervision, and training, and enabling reflection on practice and areas for improvement. And that they found it really helpful and potentially helpful in a toolkit for guiding supervisor discussion and skill development, especially in trainees, but for everybody. But that it really was less appropriate as a performance evaluation tool. And there were also concerns beyond a performance evaluation tool about the feasibility if it was required for all sessions. So I think that the therapist really gave us important feedback. And as we're potentially designing, we have the subset of ECAs, or a subset of strategies that could be included in a toolkit. They really gave us actionable feedback that we can incorporate in developing a potential toolkit. Anna, I'll turn it back over to you.
Thanks, Lauren. Yeah, it's been really actually great to return to the qualitative data as we're trying to think about what some next steps might be in, supporting therapists and programs in community mental health for children. So some of our next steps really are to convene a community advisory board of children's mental health program leaders, potential therapists and users to really identify what are some shared goals that might be met by using a tool to track EBP strategy delivery, especially when we know we've got evidence that some of those reports are related to child mental health outcomes, which we're all really invested in optimizing. So our goal then is to engage in a process of user-centered design to really co-design applications of the eco quality indicators in ways that meet the needs of our community partners, all with an emphasis on working toward the potential benefits of the tool and really being very mindful of some pitfalls might be in the scaling and use of our ECHA tool. And then we're really seeking to find partners to go after funding opportunities to support quality of improvement goals. And we've already identified a program announcement that would be a really nice fit for the next step in this work. So, really interested to hear what y'all might be thinking about the next directions for this work, and we're really curious to field your questions and comments.
Wonderful. Thank you so much, Anna and Lauren. Dr. Maya Burnett